Thanks a lot for joining in the first session of the second half of Digital Health Conclave. Thanks to each of the panelists who have joined here. Since morning, we had a very good brainstorming session on various topics related to Digital Health Conclave, basically on the National Digital Health Mission. But the panel discussion, which we are going to start now, is very important because we are going to talk about co creating a comprehensive national digital healthcare platform. The panelists here will share their insights and experience on the needs and challenges in implementing the National Digital Health Mission. And they will also share the strategies, like how this NDHM should be like implemented, and how it's going to have a paradigm shift from the traditional healthcare model to the digital healthcare model in the future. And I am very happy to introduce the eminent panelists who have joined and taken their time here to talk about this important topic. First of all, I would like to introduce Mr. Sunil Kumar Bhushan, the Deputy Director General, National Informatics Center, Niti, Government of India. Thanks a lot, sir, for joining in. Uh, Next, Dr. Praveen Kumar Khosla, the Executive Director of CDAC. Thanks a lot, Doctor, for joining in and taking time. Next is Dr. K. Madan Gopal, the Senior Consultant of Niti Aayog, Government of India. Thanks a lot, Dr. Madan, for joining in. We have Mr. Julian Sham, Head of Health Business, Asia Pacific and Japan, Amazon Web Services. Thanks, Dr. Sham, for joining in from Singapore. And uh, uh, everyone knows Dr. Rana Mehta, the partner and healthcare leader of PwC India, who is a well-known eminent personality in healthcare. He'll be moderating the session, and it's all over to you, Dr. Rana. You can take up the session. Thanks a lot.
No, thank you, Pratibha, and it's an honor being here. And I think it's very appropriate that we talk about healthcare because at the end of a pandemic, or hopefully at the end of a pandemic, we've just realized that in India we just don't have a dual burden of disease. We just don't have acute, chronic, but we also now have a triple burden of disease. So a lot of learnings as we go ahead. One of the areas which we need to look at. So all of you must have seen the statistics. On even when it comes to bed per thousand, India practically is among the last 15 countries in the world. So despite best efforts of the private and public sector, we've not been able to go. So there are three accesses to healthcare. One, I think you have a geographical access, but 70% of India's healthcare infrastructure is actually around 20 cities. The second, I think, is a financial access. So it's no point, having a geographical access if you can't. And this is where I think the government's done a great job by providing financial access to 500 million people through the Ayushman Bharat scheme. But I think these access are limited because our capital is limited, the number of doctors we have is limited, the resources we have is limited, and finally the amount we can put down as healthcare is going to be limited. So I think in India, we need a unique model. We need a technological access to care. And I think given the government's aim of having universal healthcare, the National Digital Health Mission, I think, is a creation based on digital technologies for higher efficiency and effectiveness. Because if we follow the traditional route, we are very similar to where US was in the 1960s. They spent 5% of their GDP. Today, they spend 18% of the GDP. I think we don't have the resources, we don't have the time. So we need to look at technology to catalyze this whole process. I'll begin with Dr. Madan Gopal, who sits at Niti Aayog, and that's the think tank. Dr. Madan Gopal, so what were some of the thoughts besides starting the National Digital Health Mission? And how do you see it rolling out, and what could be some of the challenges which the government anticipates? Dr. Gopal, you're on mute.
Because they have asked, it's a very interesting question because if you look at the landscape of the digital health in the country, we have been doing a lot of work since many years. I think around a decade we have started doing a lot of works. When the Modern Clinical Establishment Act was enacted and states were supposed to be adopting that thing, one of the activities in the Clinical Establishment Act was the electronic health record. We started from there. And as you have mentioned that our health system is more or less a rural-centric health system. Over the last many years, the health structure has evolved right up to 5,000 population. A structure is there, and to provide services through the structures and to provide preventive and promotive care to the services. As a result, a lot many programs have evolved. For monitoring all the programs, you are having a program MIS, which collects information from the beneficiary right up to a village level population. That sector has evolved over the last many years. Having said this, having many programs in this, we thought that if suppose I am there in a village, my data is collected on immunization, my data is collected on malaria, my data is collected on tuberculosis, and my data is collected on family welfare. How come a system is there which can at least say that what kind of services I can give if something is wrong? Because if you take the example of COVID, where we want to make an assessment regarding the occurrence of COVID in the BCG vaccinated individuals, we want to assess the comorbid and the BCG. That data is not there. You are only collecting data which has happened. If you are collecting data, my data, if something, then at least all the data sets should be talking. Having said this, the government of India has been making a lot of efforts. They have created an electronic health records. The National Electronic Health Records repository, the resource center has been made. CDAC is the custodian of that. Way back, we have done that. They have come up with a software solution to enable the hospitals to collect and make electronic records. Snowmed CD license was also taken during that time so that the ICD coding also happened. Side by side, when a lot of programs have evolved, the Central Bureau of Health Intelligence, they are collecting a lot of information. They were thought that how these data sets which are coming, they should be talking to each other. So a platform was devised, which is known as Integrated Health Information Platform, which is evolving, and most of the states, they are using that platform, in which all the program data is coming, if they are hooked to this information. That's parallelly which is going on the preventive primary healthcare side. When the Ayushman Bharat came, the precursor was the Rashtriya Swasthya Bima Yojana. And at that time, when the Ayushman Bharat was launched, there were a lot of thoughts going on that how to quickly roll out this program. At that time, the thought process started that we should be having an integrated digital architecture where all the things can ride on this. So as a result, what happened when the first phase, there was a lot of deliberation. Then the two tracks of architecture were agreed. One track was to immediately roll out the Ayushman Bharat program. And the second track, after the program stabilizes, then you quickly build on the structure so that we have a comprehensive IT digital infrastructure in which all the things can write. So the first part was very easy. We have adopted one of the state's software for quickly rolling out the Ayushman Bharat program. And we have to remember that Ayushman Bharat is having two components. One is the primary healthcare component, which is being catered by the Integrated Health Information Platform. That is the other is the PMG component, which is the IT thing which I am talking, track 1 and the track 2. When the track 1 evolved and the program was rolled out, simultaneously efforts were made for developing an architecture for having a comprehensive architecture, indigenously built architecture, which the National Health Authority is doing it. They have rolled it out as PMG 2.0. When they have rolled it out 2.0, when the work was going on, simultaneously we thought that we should be having stack. Stack means all the data should be coming to at one place with a common identifier, all the data to be talking to each other. And then came the concept of this. And a lot of deliberations have happened and a few building blocks were made, which was presented in the form of stack. That stack was deliberated and then it became a digital blueprint. And that digital blueprint is now been rolled out as a national digital health mission. And it has been piloted in few of the urban territories so as to find out how it works. It basically focuses on the personal health records and how to generate that thing, the facility record, and how that pilot works. And then the next task would be, after having this information, how it talks to the preventive side. Because the other component, that is a health and wellness wellness component of the Ayushman Bharat, that is also throwing some data. Then now that interface is also being worked out. One is from the hospitals and the patient to AMJ 50 crore electronic health records and the personal health records would be made. And the second thing is once it come to the primary healthcare, how that primary healthcare data would be collected. That's the second phase, which the work is in progress for having that kind of interface. Now currently this digital mission, one of few of the things are being rolled out in union territories with the help of National Health Authority. So ultimately, both this the primary healthcare and this PMJ thing, they would be at converging at one point, so that everybody, whatever data sets which are coming from the rural areas, because most of the people, they still the data is coming from that side only. Once they come to this, immediately the electronic health records, the personal from the electronic health record, the personal health records would be. We are progressing towards that. And recently we have released a vision document which talks about surveillance of the disease through the personal health records and the electronic health records. So we are progressing in that direction. Over to you, please.
No, thank you. And I think thank you for laying the overlay of how it is. I think one of the things also you said, we'll really need to leapfrog because, just like we didn't see internet on a PC, we saw it first on a mobile phone for most Indians. I think because this system has been protracted and takes a very long period of time. I'll come next to Mr. Sunil Bhushan. So, Dr. Madan Gopal spoke about some of the building blocks which are required for this to be done. So, how is this being rolled out? And the other component which people are very worried about because this is patient data. How do we ensure that while it's accessible, it also stays safe?
Thank you, Dr. Mehta. So let me, as an IT professional, let me start with one objective which all of us are moving toward. That is creation of electronic health record for every citizen of this country. So that is the basic objective on which we are working on. And then availability of this electronic health record in the hands of the patient. So with this objective, I think Government of India has basically published and approved electronic health record standards in 2016. And in 2017, National Health Policy from Government of India came into picture. And then in 2018, so MDDS standard for health sector was published by Niti. And in 2019, basically a National Digital Health Blueprint came into picture. Now in 2020, as you know, this NDHM, National Digital Health Mission, has come into picture. And I am hopeful with this series, 2016 onward, 2021 will be the year of health integration and making this EHR available in the hands of the patient. So I am hopeful for that. And NIC has been involved in all the initiative of Ministry of Health and Family Welfare in all the components like EHR standards, National Health Policy, then MDDS standard, then NDHB. NIC has been involved into all this. Now, we have been providing services to ministry since last 30 years. Now, let me tell you how this NDHM will, the components which have been declared by NDHM, they will be integrated with the NIC applications and how data is being protected basically applications. So one of the application, basically if you see government applications, they are primarily into two categories. One is basically horizontal applications and other are vertical applications. So if you see at vertical application, it belongs to basically uh, programs which are national program like RCH, Reproductive and Child Health, which is earlier known as a Mother and Child Tracking System. If you see BIS, if you see Nikshe TB program, so these are all verticals. They cater to a particular set of beneficiaries. And other applications are horizontal applications, which are e-hospital, ORS, and e-blood bank, like e-Shushruth. And these applications are primarily horizontal applications, which are not specific to any. They are generic for all the hospitals. So the major problem when they started development, the major problem with these applications were data was huge data has been collected by these applications. Now they are basically as they are basically developed as systems. Now many stakeholder outside the system has also demanded the data from these systems, because a lot of data has been created in this. Now then NIC and Government of India, as per prescription made by Government of India in National Digital Health Blueprint, we have moved from system to ecosystem, where all the stakeholders, where all the basically users of the data, we started connecting with them based on the parameter, based on the standards defined by Government of India in EHR standard and National Digital Health. And basically, if you look at the problem which we faced, there were three kinds of problems. So in different applications, we have different codes for same set of entities. Number one. Number two, basically, there was no unique ID to the patient. Different system, we are using the different IDs for the same patient. And the third was the format in which data is to be exchanged between the two systems was not standardized. So in these standard, National Digital Health Blueprint has addressed all the three components, and I am happy to inform you that e-hospital has become the first application which has been integrated with digital health initiatives of digital health mission made very recently. Uh, it has five components: National Digital Health Blueprint. Five initiatives have been taken by mission. That is, it has Health ID, it has digital DigiDoctor, health facility registry, PHR app, and consent management. I think mission has taken in first phase, they have taken these initiatives. So two initiative, especially DigiDoctor and HFR, they will they will facilitate the master codes. They will be used across all the health application and in facilitate in exchanging the data. And health ID will help in basically integrating the data to the various health systems. So for integration of the applications, these are the basic building block on which we have to work on. And as the data is being generated, it belongs to the ownership of the data lies with the patient. If patient is the owner of the data, in that case, whenever the data is to be shared with one entity to the another entity, so consent of the patient is very important. So we have now framework has been set by NDHM for the consent management, and we have already tested it for already integrated with e-hospital, and that consent management. We have demonstrated this to Honorable Minister also, and and NDHM has security audited this, so that we can show the data, we can share the data with the consent of patient to the one hospital to another hospital, one entity to the another entity. So sharing of data with the consent of the patient has become uh, uh, has been tested. Now it is to be put on ground. So we are waiting for that. Hopefully, from January onward, we will be testing it in 5-6 hospital initially. Then we can basically go ahead with that. And these these problems which have been troubling all of us in almost all the health applications which have been developed by either by NIC or by CDAC or by private sector. So integration was not possible without these initiatives which National Digital Health Blueprint has very well come up, and this will help basically health sector in bringing the electronic health record in the hands of the patient in a secure and in a very secure way with the help of consent plan. Thank you very much.
No, thank you. I think that that was very detailed, and it also shows us that, like for example, while we are running parallel programs, so while we know a woman is pregnant, but we don't know whether that woman actually has tuberculosis because these are siloed programs, right? So there's a loss. There's a huge loss of data because, being a clinician, her medical management needs to be very different if she has tuberculosis or not. But for a couple of decades, we don't have that information, and I think it's important because while we spoke about our allocation to health being low, we don't want our resources to be wasted. So I think this is a great. I'll bring Julian in here. Julian, you've heard about how the mission is being rolled out. What have been some of the challenges? Now, evidently, we are not alone in the world. This has been done before. So what are some of the experiences, examples, benchmarks, and learnings you think we should look out as we roll out probably the most ambitious digital program in the world?
Brilliant. Thank you for that, Dr. Benta. I'd just like to echo, my agreement with Mr. Bhushan and Dr. Gopal in terms of kind of their observations and the effort that India is progressing in terms of developing a health platform. And I think from my experience in this area for the last 20 years over 3 or 4 continents, I think the important thing here to recognize is whilst the IT may be the enabler to delivering care for both providers and patients, we have to remember that obviously the IT has to serve the users and the recipients of the care. And when we think about this, the top-down plan of the National Digital Health Blueprint and the mission and the kind of domain principles that are contained within that, things like think big, start small, scale fast, the interoperability, the ability to have open APIs. Those are different approaches that when I've seen these sorts of platforms being developed in the UK on the NHS many years past, in Singapore, in Australia, in other countries around kind of ASEAN, a lot of times people don't hold those principles to begin with, and they come at it very much from what is the immediate solution I'm going for, which are the big name brands. And there's nothing wrong with obviously some of these healthcare IT systems, but it's where are you going to use it, how are you going to use it, and what are the recipients and the providers, the doctors and nurses on the ground, how are they going to use it? The information that you capture, what will you use that for? Because obviously within a hospital environment, you'll have a depth of information for particular disease conditions. And some of those elements of the data that you collect around diagnoses and medications and lab results are obviously very, very important for other clinicians not in that hospital care environment. So if you're in a primary care environment, if you're in a community care environment, knowing things that have been done in the hospital, medications and treatments and operations that have been done in the hospital will affect and will impact on the management decisions you make. When you look at what other countries have done in the past, I think Mr. Busan mentioned it, the siloing of data in the past has prevented the care continuity to be delivered, because when we were still on paper-based system maybe many years ago, a patient's file will be in a locked cupboard somewhere, which means that you basically have to start from scratch. And if the patient is not a reliable witness for whatever reason. Maybe they're confused because of the condition. You're not able to get a decent medical history. So you're relying on imperfect information to do a medical management. Now, I think to the aims and the goals of the National Digital Health Mission, not only from the data perspective, but all the different components, start small and build fast. Don't let yourself be scared by the enormity of the delivery, because actually you can start in some areas, get confidence. And I think the confidence and stakeholder engagement allows you to then ride a wave of enthusiasm and people wanting to do this because they can see the outcomes. And what do I mean by that? The ability to share medication information prevents obviously medication errors, allows you to measure compliance, but also potentially once you've got the data to look at efficacy. Medications that are produced in other countries, are they as effective for the populations that we have here in Asia Pacific? Potentially not. So that allows you to then look at what else you need to do. So, I'll close by just saying the elements of the National Digital Health Mission, because of the phasing, because of the outcomes, because of the goals that India is looking to achieve, I think it's going to have a lot more success based on learnings that other countries have had, the ability for both public and private partners to come in and provide input, but also more importantly, because there's a patient element, a citizen element, understanding what the end consumer also wants from the health delivery systems that are being put in place. Back to you, Dr. Mehta.
No, thank you. And I think that's very interesting because, some of these areas, because the expertise lies all over and, given your insights, it's much easier for us. We don't need to reinvent the wheel because in India, given the lack of capital and that we won't get a second chance. So we need to get it correct the first time. Mr. Dr. Khosla, the next question I wanted to ask you, I think one thing which is very integral to the whole healthcare system is obviously the personal health record, right? We all talking about it, like Julian said, previously when it was physical, it was locked up somewhere and you couldn't just access it unless you visited your provider. So all that data was there, but the data was of no use, neither to the community, neither to the doctor, nor to the provider. So I think one of the bedrock has to be actually the personalized record. And how do you think this is being evolving as you're putting it together?
Good evening, all present. The previous speakers gave a very good overview of the NDHM framework, and I'll go a little one layer deeper into it. I believe to deliver a healthcare to the citizens, a very large technology-driven system, as is being piloted by NDHM, is taking shape. Now, it will be a system with wheels moving within wheels, and these wheels need to be very well oiled. They need to coexist in the system. And as has been pointed by the previous speakers, some of the subsystems of this are going to be the personal health record management system, the telemedicine, a registry of the healthcare providers like doctors, nurses, paramedics, the ASHA workers, a registry of the facilities like hospitals and diagnostic centers, a registry of the citizens with their health IDs, and further these subsystems with the ownership of different entities will have to work in tandem so as to facilitate, let's say, thousands of teleconsultations simultaneously and many thousands of diagnostic engagements as well. We at CDAC Mohali are piloting two of the most important subsystems of NDHM framework. One of these is the personal health record management system and another one is the telemedicine. Let me share my experience with these two systems by going a slightly one layer deeper into what is being discussed. Now, the personal health record is going to comprise of the prescriptions, the health data, the lab reports, the diagnostic reports, the treatment details, discharge summaries, the wellness data taken from the fitness bands, and they may be related to one episode or maybe related to a set of episodes and across multiple facilities. So that's the challenge. And the benefits are enormous. You and me may not know what immunization you've gone through in the childhood, but the PHRMS will know it. We may be on the medication for diabetes and blood pressure, and we might forget to take it, but the PHRMS would remind us. And these are the features we have already built into the PHRMS that we have developed. There can be a government PHRMS, as is being done by CDAC Mohali on the with the funding of MHFW, or a private PHR, some of which will spring up in due course. Now, this PHR is like a money in the bank. The as has been pointed out, the PHR belongs to the patient. Now, the patient would decide where his PHR would reside, and as per his consent, and he can withdraw that consent as well anytime. In case of bank, the money gets transferred from one place to the other place, or one entity to the other. But in case of PHR, it is shared. It is shared with one person or the other person as per the consent of the patient, and he can withdraw anytime if he wishes to. The consent is facilitated by the consent management framework, which has been spoken about by Shri Sunil Bhushan, which they are developing in NIC. Now, as the PHR remains, the ownership of it remains with the patient, it is available to him all the time. He need not carry voluminous papers. The doctor is able to take more informed decision by improving the quality of healthcare, because he has all the data with him now. Another sector which is going to immensely benefit is the insurance sector. With such a framework, insurers will know the facts about the patient before they undertake insurance. And another most significant is going to be the analytics, like what kind of diseases are occurring in which area and so on, which will bring about improvement in the overall health of the citizens. Now, a health system of the government, the organized corporates, the smaller hospitals, nursing homes, diagnostic centers, and clinics will be the feeders of the EHR for the patient, which will be stored in the PHRMS and as per the choice of the patient. PHRMS will provide also the web application and the mobile application through which the patients and the doctors can view their records, or the anyone who's consented to see it. 3 years ago, one of the versions was rolled out by us. The adoption of that has been rather low, and we need to look at why is it low. I'll delve on that also. And the second application I would like to talk about, the telemedicine initiative. Again, CDAC Mohali, which I'm heading, is the developer of this application named eSanjeevani. It is again funded by MHFW with a lot of input from them. And the major salient features of these are, it's emerging as the largest telemedicine solution, which is technology driven with audio, video, chat, not the one on the telephone. There are others on the telephone also, which may have a larger presence. But our geographic spread is pretty high. There are going to be 1,55,000 HWCs by 2022, and they will all have our telemedicine infrastructure in place. It's following the hub and spoke model. Mostly the medical colleges and the district hospitals are the hubs, and the HWCs are the spokes. And otherwise, the patient can also talk to the respective state government offices, doctors directly. Now, the telemedicine solution named eSanjeevani has been rolled out in 28 states of India. The major states which are conducting large number of telemedicine consultations are the 4 southern states, 2 western states, and then MP in the center and Himachal Pradesh. These are the ones who are conducting very large number of consultations, and we have so far done more than 1 million teleconsultations during this year, approximately. Now, in this solution, we have 26 general OPDs, 190 specialist OPDs, including these super specialty OPDs. There are around 20,000 doctors and health workers across the country who've been trained on this system. And as has been pointed out by the earlier speakers, the EMR guidelines, which have the standard which has been rolled out, we are the beneficiary of that. We are able to pull in data from different places, and interoperability has begun to show up. Some of the challenges that I would like to mention here is, one is the reaching out to the people who are unconnected or digitally illiterate, or they are in the remote areas, hilly areas, or the tribal areas is a challenge. Literacy and awareness will require to be at a higher level, because the patient, like it was pointed out, has to give a consent. Now, consent means he also has to mention for how long the consent is given, when can he withdraw that, for how long the hospital or a doctor can view his records, and what can he view, entire set or a partial set, and so on. The internet penetration may be about 40%, but I'm hopeful with the BharatNet and the PM money being announced by the government of India and making a progress, this situation would definitely improve. The adoption of technology has been rather low. Uh, uh, I would say in both the cases, in eSanjeevani also it's low. In case of personal health record management systems, it is very much below the requirement. The potential of eSanjeevani is much more than this. We are conducting about 10,000 consultations per day, and our potential is much more. But the adoption of technology is very low. I've seen even in the states like Punjab and Haryana, where the advertisements have been there, still the adoption is very low. The factors which can bring about improvement are the engagement at the grassroots level. The a good experience of a patient will go a long way to spread the good message and also bring the repeat consultations. And it's something like, suppose he's waiting for a doctor for quite some time, that he'll come and share some words of wisdom, but when he comes, he's partially appearing in the picture, or maybe uh, he is not really appearing to be empathetic with the patient. So in case those things improve, it will be a delight for the patient, and obviously the penetration would improve. Uh, the other part is the interoperability. Interoperability, although some efforts have been made so that all the systems coexist, because it's a system of wheels within the wheels. There are multiple IDs. There is challenge of data privacy. There are challenges of security. There are challenges of imported equipment, whether conforming to R&DHM standards. Uh, and uh, the patient would like that the data, whether he consults a doctor in Apollo or Max, or he undergoes a CDAC teleconsultation, uh, he should be able to go anywhere he likes and his data gets ported to those. But there are challenges in that. And another thing I would say, okay, we have moved on from telephone-based consultation to the audio-video chats with the demographics and the reports being uploaded. But still, um, there will be a time would come shortly when the doctor would say he's not happy alone with the chat. There should be some point of need devices also which take the vitals of the patient and share with him. The efforts in entering data which the doctor puts in, that needs to be addressed. Maybe the transcription industry has some solution to it. The standardization of data has been talked about earlier, and it's fundamental to the requirements of the artificial intelligence based or business intelligence based analytics. This is a well-known fact. As we understand it, the biggest challenge in the standardizing is going to be the disease code as per the international standards. There are other entities also like PHR, that the labs, the doctors, the healthcare workers, the pharmacies. If you want to build e-pharmacies tomorrow, which we are also trying to do ourselves here in CDAC, we realize the chemists or the pharmacists, many of them are not even on computers, or if they are on computers, they have their own system of maintaining it. They have their own softwares. So how do we talk to each other? So those are the challenges which need to be addressed, and standardization will go a long way in that. There needs to be a fine balance between the healthcare of a patient and also right to the safety and security of the healthcare worker. So the legal system needs to look at it. Another part which we face during the implementation in the eSanjeevani, the often the OTP service, we rely on the one-time password which reaches the mobile phone to authenticate him. Now OTP service goes down, and imagine if it goes down, and it does go down for more than an hour also. And you imagine hundreds of doctors and patients are waiting in the queue to attend to the consultations, but just because the OTP service is down, and other methods of reaching the patients are not so easy because of the digital divide. So those are some of the challenges. The affordability is another challenge, which I feel if the NDHM can own a health cloud for the NDHM ecosystem, which is made available to this and available free of cost to the stakeholders, that will go a long way in improving the affordability of the consultations. Um, Our experience of proliferation of telemedicine, now that we are there in 28 states, many more can learn from it. Like e-pharmacy is also waiting in the wings to uh, get on to the NDHM bandwagon. Uh, AI, the artificial intelligence based solutions can reduce some burden on the health information providers. But again, as the telemedicine guidelines have been rolled out this year in April, that shows that these AI systems can only help the doctors and not patients. Maybe the day comes when it attends to the doctors as well. The complexity of language, because each state has its own set of languages. The system of having two languages, maybe one native language and English as the another language, may solve problem partly, but it considerably increases the size of the database and also the challenges, technological challenges which are associated with it. The computerization of pharmacy, I've already spoken, is a need of the hour. And I would say the NDHM uh, ecosystem, if improved upon, can really become a world-class service. I can conclude by saying that the healthcare and the technology perspective, the NDHM can be a good platform to launch. The real fruits of today's efforts would be reaped perhaps maybe a decade from now. But that too would happen only if we start today and think big, start small, scale fast. Thank you.
Uh, Thank you, Dr. Khosla. I think very interesting. You took us through all the problems. I think the whole idea is that we put in the building blocks, but replicability, scalability, adaptability is very slow. And, I mean, there are multiple reasons for that, both in the private and public sector. I'll go back to Julian and say, Julian, you've seen, what these issues have been common, but today globally you're able to using the cloud replicate and give a different sort of one of the things came is the experience is not optimum, and that's why clients don't come back or patients don't come back or they don't use it. So what are those learnings which India can do it so that we can really capitalize this? We could not be waiting for another 10 years to say, okay, we're trying to get it right. We just don't have the time and the energy to do that. Julian?
No, I hear you, and everything that Dr. Kosla's described all resonates with me, having seen it over the last 30 years in healthcare. So all completely resonates. I think what we've seen, certainly from AWS and as a cloud provider, and one of my kind of cheesy quotes I normally say to my customers is, you need to concentrate on the science or the medical care you provide, and you let us help you look after the technology that you need to deliver that. And when I say that, it's, obviously some of them have a wry smile, but I truly do believe that's my mission and my team's mission is if we can understand what the problems are or the clinical workflow or the care that's meant to be delivered, can we work out how the technology in the background can help streamline, the right patient to the right person with the right information at the right time, the five rights. And what we've seen during COVID, but even before COVID, was, the people using health IT and digital health technologies, things like telemedicine that we've already described, things like pharmacy distribution, clinical decision support systems, virtual chatbots and virtual assistants to help answer questions. A lot of people were using those in kind of an abstract manner before COVID, but COVID actually really focused everybody's mind in terms of because of the limitations. Everybody was on lockdown. Travel wasn't allowed. People were afraid of going to clinics and going to hospitals for fear of catching COVID. So then remote monitoring and remote care and remote access to healthcare became one of the buzzwords as a means of accessing care for anything other than COVID. So San Giovanni, that's been mentioned, obviously that's a very successful telemedicine platform. There are other examples in India like Dozy, in Australia we have Care Monitor, where they use Care Monitor to actually, once a patient had been diagnosed with COVID, instead of admitting them to hospital and taking a bed up, they were looked after at home using a mobile app and some IoT devices like a pulse oximeter, temperature sensor, blood pressure machine. that still then allowed the clinicians in the hospital and the clinics to keep tabs on the patients, but in the background, using the remote connectivity, using the AI algorithms, if there was a change, you could contact that patient quickly, do a video consultation, and then make a management decision of, do I need to admit them? Are they somebody that, based on their demographics and cohort segmentation, are they going to require ICU intervention? Kind of going beyond that from a cloud perspective, I think all the things that Dr. Khosla mentioned, the scalability, the think big, start small, scale fast. Again, things like using cloud services has allowed people to experiment at a small scale for not very much money. These are cents, dollars and cents kind of thing, and start building up applications. And once they've proven whether the application has worked or not, then decide whether or not they want to scale it out. And the ability for them to do that literally within hours is phenomenal. There's a professor, Patrick Brennan, out of the University of Sydney, who's a consultant radiologist. So one of the things that they built during COVID was an education module to teach radiologists in other countries how to interpret COVID positive and COVID negative X-rays and CT scans. It was something that they had on a server in their building. But after they converted it to a cloud-based format, within a week of them switching it on and making it available free of charge, there were over 80 countries. So radiologists from 80 countries around the world had signed up for these education courses using an AI and ML to help teach them what to look for before COVID hit their shores. My conversations with Prof. Brennan the last week, there's now 145 countries that are still using their education model to teach the clinicians what to look out for and how to determine the severity of the disease. So one of the benefits we've seen with cloud is the agility, the flexibility, the scalability, but also, in times of need, the cloud's able to take over some of the demanding workloads that customers have required, that if they'd done it the traditional way with data centers and servers, there would be that procurement phase where they'd have to order the server blades, the CPUs and everything else. But using cloud, they've been able to pretty much experiment, test things out. If it doesn't work, change your direction and do it within a short space of time. Looking forward, kind of in 2021, I think my government level customers, my provider level customers, and the startup customers that I work with, they're all looking at how, and again, it comes back to some of the kind of principles of National Digital Health Mission, interoperability, APIs, sharing of information in a secure manner that allows the analytics, the AI, and the algorithms you build in the background to augment clinical care, not take over from the doctors or nurses, but augment what they do and remove the repetitive actions that they shouldn't need to do so that they can focus on providing patient-specific care. I'll hand back to you, Dr. Mehta.
No, thanks, Julian. I think that was very insightful, and it also shows that you need not you can catalyze all this in a couple of weeks. You don't need to do it for years. I think as the final question, as we tend to close down, I think is I'll start with Mr. Bhushan. If we would look at the National Digital Health Mission in another couple of years, say in 2025, what are 3 things you would say would count for success? Saying that if we achieve this as a country, we know we are on the right path. You're on mute, Mr. Bhushan.
Okay. Am I audible?
Yeah, you're audible.
Okay. So there are a lot of things. I think security and privacy, we have to do a lot of work on that. So because the data protection law is going to come, so act will be there. So we have to work very hard on that. And it's really a challenge. We have lots of personal data. We have a lot of health data, which is very sensitive. And we have to work on that. And there is a lot has been said in the National Digital Health Blueprint So there is a chapter on standard and regulation, and in building block also the lowermost layer is on security and privacy. I think that is the one challenge we are already facing. We have created about 10 crore records in PMJ, which have been well authenticated using Aadhaar. So we have been, because it's a personal data. So challenge is there. We are encrypting, and it has lots of challenges. We are working on them, and I think this is one area. Another is basically we have to make the people aware about it. People are not aware about the technological initiatives of the and how that can be made available, how it can be benefited. Even the educated people, they are not ready. See, one of the things is very important. We become health data conscious when we are sick. When we are okay,
Right.
we don't care. So this is, I think, this is the most critical thing we have to learn. We have to maintain our data even when we are okay, so that we don't fall sick. So we have to create a lot of awareness around it. And there are technological components. We have to work on that, because only 2 registries have been put in place as of now. So there are a lot more registries have to place. They have to be created, and ownership has to be given by respective, say, health say departments. So when they maintain it, so maintaining creation is one thing. Maintaining the registries is another challenge. So we have 2-3 major challenges ahead.
Right.
In next 5 to 10 years. So, and we are finding solutions for that also. We are positive on that, and NDHM will definitely help us in sorting out all
Thank
these
you. I
issues.
think you articulated it very well. While I think the challenges we are rising to that, and um, so Dr. Khosla, very briefly, what do you see as the 3 areas which would count for success for NDHM?
Yeah, to my mind, the success would depend upon very many factors, and whose perspective is it? First of all, there can be a system of rating by the beneficiary or by an artificial intelligence based some analogous algorithm, which can be piloted by NDHM. And it will go a long way in improving upon the system and also bring about the successes. The success criteria would differ from the perspective of the government or the people or the healthcare providers. Now, as a patient, if I can get my data about my health or the disease, share them with another doctor or another hospital of my choice at a different place, and that too hassle free, I would consider NDHM is a success. Now, as a doctor, if I can give faster and accurate services because I have access to the patient's past record, I can take more informed decision. That would be considered a success. Similarly, if I can reach out to more patients with the help of technologies like telemedicine apps, AI, NDHM is a huge success as a doctor for me. Now, as for the government is concerned, there may be many criteria for success which needs to be clearly defined. And also another point is that there are people with the habits like, let's say, smoking, drinking, consuming tobacco, and these habits have direct impact on the health. Now, um, will NDHM be successful if it burdens the rest of the people with the healthcare of these people, this lot or not? So there are very many criteria which need to be followed to make it a success. But yes, we should define that, and we should bring in a system of rating of these with benchmarks of some good hospitals. Let's say if the neurology of PJ is good, how is the neurology of NDHM? So some benchmarks like that would go a long way in deciding the success factors. That's it from me.
No, thank you. I think that's very important. Ultimately, I think we we've been pushing a lot of these technologies. There's no pull from the patient side, So how do we get them also involved? Integrate. And this is not only in the private and public sector, both sectors, I think, equally, where the patient is aloof from the system, like you mentioned. He only bothers about the system when he falls sick. But I'll ask Dr. Madan Gopal to have the final word. How does he look at, success in 2025? Dr. Madan Gopal, you're on mute.
Okay, sorry. Okay. One of the important thing, Rana, what I look at is we have been pushing for technology, and we are envisaging that the technology would be put into practice. But it's the other way around now. That means if we are able to build practice into technology, then the uptake would be more and the success would be more. That's the biggest thing. How we balance it out, that's the challenge lies. That's it. We have been always pushing the vice versa. We are pushing the technology into practice, but it should be the vice versa. How to augment the practice with technology and how to balance it out. That's the biggest challenge with the NDHM and any other technological program which is related to medical field. The second is we are talking about electronic health records and the personal health records. As of today, if I go to a hospital, whatever investigation, whatever prescription that hospital is providing, if it is referring to a higher center, the higher center doesn't recognize that records. It will create their own records, they will create their own diagnostic, run their battery of tests, and they rely on that. How to standardize this thing? That's the biggest challenge. How to have a standard? If the personal health record which are there, whatever is filled in that with a particular this, how to standardize that thing, how to ensure quality of that record so that once that record is accessed by some others, it is being honored. If the records, after making so much effort, if it is not honored, then the whole purpose is defeated. Third thing is the awareness. People are still not aware. Once they are going outside, they try to digitalize all the records. But that awareness component, I agree with my previous speakers, that is missing. These are the three challenges. If we are able to address that, I think we would be having a successful program. And the other, never the least, is integrating with the other component, that is the health and wellness component of the NDHM part. We should not forget about that. In fact, they act as gatekeepers. They will be feeding the patients to the other system. Thank you.
No, I think very well articulated. So I would say that, as we conclude, I must thank my panelists. I think we've, in due earnest, India has started that journey where, we will provide technological access to care. This is the first step, universal healthcare. And we are basing it on digital technologies because it will reduce waste, higher efficiency, there'll be better effectiveness. Because while our spend is low, we need to be much more effective. And we've seen that it's happened globally. So there are a lot of learnings, as Julian told us. We put in the building blocks, but, the whole thing is that we don't need to walk. We probably need to run to make sure that all people have access. And secondly, I think the whole focus is it has to be around the patient. He owns the record. He needs to get confidence. He needs to start using technology. Technology is a great facilitator, but I think rather than push it onto him, he needs to be attracted to this. So I must thank all my panelists. It's been a wonderful session, and I'm sure we'll come back a couple of years later and see, this is where it started, and it's really taken off. Thank you, gentlemen. Thank you.
Yeah. Yeah, thanks a lot to Dr. Rana for moderating the session so well, and to each panelist here for taking up the deep insights like how we are going to begin the NDHM. We'll not wait for 5 years, Dr. Rana. We'll keep meeting and discussing about it as it goes. We need to know. We need to have more such sessions, and we need deep insights of thought leaders like each panelist over here. So we'll trouble you again and again. I hope you people will join Elets and share your thoughts. That is very much needed. Thanks a lot to each one. Thank you.
Thank you. Take care.
Thank you.
Thank you.
Thank you.